Voilà, sourire. Ah, perfect. Ok. Primo, quiero agradecer a la SLARP por la invitación y especialmente a Mario Pellizzari, Ricardo Pérez y José Lipsit por sus amistad. Pero voy a pedir la indulgencia de todas y todos, porque voy a hablar en inglés o en francés, pero cuando hablo en castellano, José me dice siempre que hablo como Don Diego de la Vega, el zorro. Muchas gracias. Okay, so I have a topic which is not necessarily as enthusiastic and brilliant as other. I'm going to speak of scoliosis. It's a very old disease, and here you have the evidence showing you that the orthopods are using scoliosis as somewhat a main key product, with this very old picture representing a tree and a tutor. So I wish I had disclosure to do regarding finances. I don't have any. My objectives are to present the concept of adolescent idiopathic scoliosis and early onset scoliosis, to present the evolution of spinal instrumentation to treat these two entities, and to present the imaging findings of the most frequent post-operative complication. The last objective will be the second talk, to discuss recent imaging modality referring to scoliosis. Regarding terminology, we have to understand very clearly that there are two kinds of scoliosis. Adolescent idiopathic scoliosis, which is defined as an idiopathic scoliosis with onset after the age of 10 years, and early onset scoliosis, which is defined as a scoliosis with onset before the age of 10 years, whatever is the etiology of the scoliosis, malformative, neurogenic, or any other etiology. This is key to understand the therapeutic challenge related to these two entities. Okay, I can shout. So here are the treating principles. For adolescent idiopathic scoliosis, the treatment is posterior spinal arthrodesis with instrumentation, most of the time close or after skeletal maturity. In case of early onset scoliosis, the implants should correct the deformity, but without spinal fusion and without impeding the growth of the spine. This will mostly require frequent periodic adjustment, and this will also allow the growth of the lungs. So here is a very rapid summary of everything that we can use. So arrow is here. If you start for the adolescent idiopathic scoliosis, historically you start with Harrington rods, then Luque Galveston implant, segmental spinal fixation, and now anterior release and implants through thoracoscopy. When you go for implants used on early onset scoliosis, you have growing rods, Vepter, hybrid rods, and magnetic rods. You can use also compression implant for vertebral staples and tether, and you have finally, more recently, guided growth with Luque or Sheila implants. Harrington rods were invented in, well, when I was a resident, when I was not even in med school, in 1960 by Dr. Harrington, and it's a distraction device with a proximal and a distal hook. And it's very rude, but when they do the surgery, they place the hooks on the pedicles, and during surgery, they just distract. So you can understand that there are very strong forces at the extremity, so there is possibility of fracture and dislodgement of the hooks. And furthermore, there was very little control of the sagittal deformity, and the patient were ending with a flat back syndrome. Furthermore, in order to let the arthrodesis, the bone chips around the rod, to make a nice callus, the patient were required to have a cast, a body cast, for 9 months. It was very, well, now we don't use it anymore. It was very unpleasant for the patients. Then Luque decided that there might be something a little bit more little bit smarter, and he created a device which in fact provide segmental spinal fixation. These are two L-shaped rods, so they are L-shaped, so they would not move up or down, and they are connected to the spine with sublaminar wires. The spinal fusion is slightly more extensive in Luque than in Harrington, but there is no need for postoperative casting, which basically was the main reason for Luque to invent that, because in Mexico he did not want his patient to stay in a body cast for 9 months. It was extremely unpleasant for the patient. And in this case, the rods are slightly curved, so you can have a spine which is looking a little bit how it should be, contrary to Harrington, where patients were completely straight up. In this case, you can see that you've got two rods, and you can see that you've got some fractures on the rods as well. When you have a fracture, this implies that the arthrodesis is fractured close to the site of the rod fracture. Finally, spinal fixation came, and using the Luque principle of a curved rod and segmental instrumentation, the Cottrell-Dubousset and the equipment developed in Texas Scottish Rite Hospital were able either to distract on one side and compress on the other one, where they went through laminar hooks and pedicular screws. We cannot make the distinction between those two. The change is just that for Texas Scottish Rite Hospital, it's easier if there is a problem to dismantle the system, when for Cottrell-Dubousset they need mostly to break the rod and get it out. Luque had a variation which was called Luque-Galveston, which is for patients who are bedridden and you want to make them able to sit up, and this implies the use of rods getting implants in the iliac wings. This is the initial design, and you can imagine that it was extremely difficult to ram the lower part of the rod in the iliac wing, then to move the rod to the spine and to do the surgery on the spine. So now everything is almost the same way, with implants to the iliac spines that are distinct from the spinal rods and which are connected through connectors. More recently, there has been surgery done anteriorly with thoracoscopic approach, which give a better immediate result in terms of discharge of the patient. And basically, there are screws in the pedicles, lateral screws in the vertebral body, connected through a rod, which can be done thoracoscopically. In case of early onset scoliosis, the guiding principles used for adolescent idiopathic scoliosis cannot be applied to a growing spine, because they would impede on lung development and would impede on the spinal growth. So other devices and technique has been developed to correct and prevent progression of the curve, and also allowing the longitudinal spinal growth. The aim of that is to delay the fusion surgery as much as possible close to skeletal maturity. So you've got devices which are basically distractions, similar to Harrington, with the forces at the extremity. Usually they apply traction at the spinal column between proximal and distal anchors. The dissection is limited and the implants are not placed on the spine itself. There are muscles between the rods and the spine to prevent spinal fusion. The rods are periodically lengthened, and the children can grow, and in order to maintain the spinal curve correction. Just like Harrington rods, they have very poor sagittal control. So here is a traditional system. You had two rods with a device in between. Here you had a spinal fusion which is very limited. Here you have another spinal fusion which is very limited with pedicular hook, pedicular screws. And in a boat, the turnbuckle is mostly used to make the ropes very tight. Here you just use them the other way, and on the contrary, you expand in between the proximal and distal anchors. Vector has been initially used and designed for thoracic restriction syndrome in order to provide the children with a larger and a wider, a bigger thoracic cage. But it is used also to correct and maintain spinal deformity within a reasonable limit. Here you've got an example where you have the original Vector with rib-to-rib connector. These connectors can be every 6 months expanded, and here you have patient at, I would say, diagnosis, and he is 11 months, and then when he is 3, he got the surgery at the level of the ribs, as well as a hybrid system connected to the rim proximally and to the spine distally. At that moment, you see 5 years later, yes, there is still a curve, but it has been expanded and the lungs have developed. Vector can be rib to rib, can be spine to spine, can be most frequently hybrid with spinal connection at the lower part and rib connection at the upper part. You can even have compounds with pelvic anchoring, just like in the Luque system. In case of hybrid growing rods, just like we have seen one, they are providing better results and less complications than the classical growing rods. This device has been it's very, very smart. You have rods which are with a spring inside. The spring is compressed, and periodically with an external magnet, the surgeon is able to release the ratchet, the spring expand, and there is no regular surgery. You need just to have regular visit to have the device adapted. So here you got the exam from the vendor where you see the patient having the magic wand over her back and the spring expand, and there is no need for surgery. Here you've got an example of the patient with a pelvic implant, and you can see that there is a very small gap, and then progressively the gap goes bigger, and 1 year after there has been growth of the spine, growth of the lung, and the deformity has not significantly progressed. You can also have compression devices, which are mostly represented by staples, as in this case, and tethers, as in the next one. They are used to correct scoliosis close to the end of skeletal maturation, and these staples, which are bridging every, I would say, hemidiscs, are placed thoracoscopically, and the way they work, it's very similar to the surgery for a genivalgum correction at the knee level. And by blocking the growth at the convexity, you expect that the growth at the concavity will progress, and at the end of growth, at the end of skeletal maturation, the spine will be straight. Here is an example of another compression device, which is a tether. You've got screws with holes, and between the hole, through the holes of the head of the screws, you've got, I would say, a string, which is placed through that, connected to the screw, and which prevent the growth of the spine on the convex side. Finally, guided growth implants are even more clever, because you have screws which are strongly connected to the rods, the red ones, and you've got other ones which are in fact more like guide, providing possibility of the rod to slide. So you have two main ways to do that. You can have your anchors at the extremity and it will slide in between with two rod, a little bit like for the growing intramedullary nail, which could be used in osteogenesis imperfecta. Or you can have a piece of strongly connected screws in the center of the device with long rods which would slide through it. Here you've got an example. You see that it's the part of the proximal part of the rod is significant, but it will be, I would say, retracted through the screws which are there. Here it's very, very strongly connected, and here it's loosely connected, and it will allow the rod to slide. Even smarter, this guide has designed screws which are, he's Canadian, which are here providing slide without metal-to-metal contact in order to avoid metallosis, and it's relatively, it's efficient. Nevertheless, we don't know exactly what is the long-term result because you have more dissection in this system than in the other, and there is always a risk of spinal fusion close to the sliders. This has been developed recently by an Israeli group, and it's also extremely, extremely smart. So you have a ratchet and you have a joint here. The rods are strongly connected here and here, and the device is on the convex side, and the patient is asked to do some ballet extension like that regularly, or hanging from a door jamb, and every time he does that, the ratchet moves a little bit, click, and after it cannot come back. And that's the beauty. Your patient will do it by himself or by herself. There is no need for re-surgery, and it corrects the scoliosis. There is one caveat that you will see later on. Okay, now we are going to speak. I think that I've reviewed almost everything in terms of implants. There are complications, and the problem is that there is no strong guideline regarding how frequently you need to image the patient in order to figure out if there is a complication. In case of spinal fusion, usually there is X-ray immediately after surgery at 6 weeks, 3 months, 6 months, and after every year for at least 5 years. If you are using growing rods or growth-friendly equipment, you need to do imaging almost every 6 months at least before every lengthening procedure. The complication can be immediate and could be impressive, but in the end are relatively simple. You can have a collection at the site of the implant, and you have an example. It's a mix of blood and CSF. Usually it's resolved, but it could be extremely impressive on the CT. This is weirder. Pelvic implant ectopia. So let's say you have a patient who had a Luque implant, and the screw is just getting completely out of the iliac wing. The screw has a certain thickness. The iliac wing is extremely thin, and you understand how easy it is for the surgeon, even with a plain film during the surgery, to realize that it's off. Little bit more worrisome is that you can have a pedicular implant ectopia. So it goes with how the surgeon is placing the pedicular screws. He's drilling a very thin hole at the posterior cortex of the pedicle, then advancing a probe gently to get to the vertebral body. Then he is advancing a screw, and the screw is supposed to follow the path of least resistance and to advance in the vertebral body. Sometimes it's not exactly the case, so this one is outside of the spine, luckily respecting the aorta. The other one on this patient is in fact inside the spinal canal. On the MR it was pushing away the cord and there was no neurologic deficit. So these were kind. This one is worrisome. So the patient had Apifix system, the most recent system, and there was something wrong with the way the scoliosis was behaving every time the patient was doing the gym, but on the plain film, it seems that one of the proximal pedicular screws was slightly off. We did a CT, and obviously, yes, it's completely off. And when you look at the aorta, you wonder very seriously if it's in the aorta. And of course, it was not placed initially within the aorta, otherwise the patient would be likely dead. We are probably 3 months after the surgery, but something went wrong. So it's a little bit like when you have the bone, it's going out progressively, swiping off the pedicle. And we did a CT with another CT which was much more gated, etc., etc. And finally, the decision, of course, for the surgeon was to remove the screw. But how would you control the hemorrhage if there is an hemorrhage during the surgery? So it was a combined procedure with cardiology and a balloon within the aorta just in case, and a very precocious removal of the screw and the placement of a new one, slightly different, but finally with only very minimal, okay, yeah, it's here, very minimal indentation on the intima, which implies that it has never been in, it was making a strong indentation on the aorta, but it was not within it. We spoke a little bit for Harrington, but this can occur for any kind of hook. The hooks which are connected with the pedicle can move back. When you have the vector, you can have the same thing where the vector would go through the rib. Here it's properly engaged on the rib, here as well. And with time you realize that the cradle has gone through the rib reforming itself distally. You can have a fracture of the rods. We have seen some. It can break anywhere. Here it's on the spine. Here it's at the connector. Every time you have a fracture of the rod, there is a pseudarthrosis. This is normal appearance of the spinal arthrodesis. And here you can see that you have a pseudarthrosis. Same thing, you can break the rod, you have a pseudarthrosis which is posterior, but the intervertebral disc anteriorly can degenerate because the movements now are transferred to the intervertebral disc. Finally, there is a windshield wiper effect. There are some very limited movement at the pelvic, at the junction between the spine and the pelvis, and these movements are transmitted to the Luque, the Galveston implant, and they can create some loosening chamber. The good thing is that if they are smaller than 3 millimeters, there is no big deal, and at the end of growth, at the end of everything, it does not affect the final result. So here is an example similar to the one of the patient with a screw in the aorta. You realize that, yes, it's correcting progressively, but instead of correcting completely, it's mostly because here at the joint on the implant, there is a decrease in the alignment. So one of the screw is correct, but the other is loose. And because of this loose screw, instead of having, it creates another point of pivot for the device proximally. Okay, you may have an infection. In all the case where we had, in all the patients where we had an infection, it was never diagnosed on imaging, but always on biologic findings. You can have excessive soft tissue formation. You can have neurological injury, especially in case of sublaminar Luque wires. You can have some reduced bone density and compression fracture just below the distal screws. Okay. Wow, I made it. Okay. Okay. And I have one more now. Can I move to
con la segunda clase. ¿Sí?
Pardon?
Okay, yeah,
but where? I don't know. I cannot find it. And I think that the question will be at the end.
Dejamos las preguntas para después, ¿sí?
Sí, creo que se necesita. Je suis pas doué. I'm not that smart. Thank you for the
Bueno,
mouse.
buena inversión. Las charlas.
So I'm not going to interfere with the previous talk, and this one is more in the direction of what are the... Okay, I can bend my knees, I don't know, just like a Freddie Mercury. And anyway, okay, so there are a few scoliosis. It can be boring, but if you are just a little bit interested, you will find it very, very interesting. So, no disclosure, and I will not speak that much about CT or 3D capacity. I will not speak about MR regarding scoliosis. I will speak mostly about linear slot scanning radiograph, the so-called EOS device. Okay, this is, I think, a very important advance in scoliosis imaging. So this was invented by this guy who was working in Geneva for the CERN and invented a device which can measure very, very limited, very, very small amount of irradiation. And it was the thread chamber that he invented. And then for that invention, he got the Nobel Prize in '92. And after, there was a development of the thread chamber to make that something possible for imaging. So you have, in fact, two sources of X-ray, which are very, very thinly collimated, with, on the opposite side of the booth, a detector, and the two couples of tube and detector are moving simultaneously up, moving down, and are acquiring a AP and a lateral view of the spine at the same time, with a very minimal amount of irradiation. Nevertheless, it's very good, but it's not completely perfect. So here are some examples. This is what we are used to see. And in some difficult patients, this is what we get. Here, I would say I lose everything. The same patient, because of the adaptive system of the thread chamber, give you a much better contrast for roughly 1/10 of the irradiation that you gave on the lateral view. You can see this is regular Nova Scotia size. Patient is quite large, and despite that, you have a relatively good contrast at the thoracic and at the lumbar level. Furthermore, in dedicated case, we are placing some landmarks on the vertebra, on the spinous process, on the transverse process, and we will see later on that this gives to the surgeon additional information that we would not have, which could be very difficult to perceive on the usual plain film. And this is done for a significant less amount of irradiation. From this AP and lateral simultaneously acquired, after the process of placing the landmarks, you can obtain what is a model. It's not a 3D reconstruction. It's not CT. It's a model. That means that the computer decide based on a library of shape which vertebra is fitting and place the vertebra to make a 3D model. But this is obtained for a 1/100th of a CT radiation. The vertebrae which are colored are the ones which are considered to be the neutral vertebra in blue, and in yellow are the apex vertebra of the two curvatures. From that, you can generate very fancy report with measurement of a lot of variable, but the thing which is the most important is that you can have an assessment of the degree of rotation of each and single vertebral body, which was previously not possible. Okay, you can also have some assessment of the pelvic tilt and pelvic rotation or pelvic tilt. So you have the patient. This was classic. You get this kind of reconstruction, and then finally you have your model. The surgeon can have whatever he wants in the way he wants. He can make as many indices of rotation that he like, because before, now they are very excited because before they were strictly unable to do that. Dose reduction in scoliosis is very important because scoliosis is a chronic disease with multiple X-rays, and you may have to use CT to get a 3D rendering, and it has been shown in this paper that there is an 8-fold increased risk of breast carcinoma in adult female who had scoliosis and were treated for scoliosis during adolescence. So it's important. Nevertheless, there are specific artifacts, but they are not the artifact as we are used to see in X-ray. There is very limited problem of under or overexposure. When the patient moves, there is no blurring, but you have undulation. You have some beam hardening artifact around implants and around the mediastinum and the diaphragm, which may cause pseudo-pneumomediastinum or pseudo-pneumoperitoneum. Okay, and if the patient is not placed correctly in the center of the booth, you may have some appearance of skeletal dysplasia. Some example, so if I have, okay, here we are. So there is no pneumothorax, there is no pneumomediastinum, it's just a beam hardening artifact, usual with that. This patient, yes, has bilateral knock knee, but this kind of undulation here is related to a little bit of a shiver at the moment of the imaging, because imaging, the scanning is roughly 8 seconds. So you need to have a patient who is standing still. Same thing here. This is not a pneumothorax, and this is not a cardiac aneurysm. Finally, these rods are perfectly rectilinear, except that on the X-ray, they are undulating. There is one caveat, is that the surgeons are so enthusiastic that any patient requiring any imaging for them, at least in my institution, end up having this EOS imaging. And it's something which I have to fight to some extent, because when the patient is in pain, well, it could be something else, and I would strongly prefer to have segmental views of the thoracic spine and segmental view of the lumbar spine. They ask for that. So this patient has scoliosis, question mark, back pain. Any comment? Ok, se puede ver algo abnormal. Yes. So the patient has 2 vertebra plana. I missed them. Okay? So it's and it's something which is also even more important when they ask for a repeat, because frequently for the repeat they ask for a microdose where the dose is even 10 times lower than for the initial imaging, and you end up having some difficulty sometimes to see the bone limits. So be careful. I'm going to speak about some things that we don't have, but you will understand why I'm speaking of it. It's what is called an O-arm. That means that the surgeon, when he's placing the screws in the pedicles, instead of probing with a very thin metallic wire, will in fact do a few CT slices. It's absolutely fantastic. There is a very precise guidance of the screw, but there is a big irradiation burden. Nevertheless, you remember this patient, it's sometimes probably better for the coronary and for the adrenal of the surgeon to have absolute certainty. In terms of post-op monitoring, EOS is also nice. So if you look very carefully, you should be able to see some very small lead points which are on the spinous process and other which are on the transverse and on the pedicles. And the general idea is when you will monitor and repeat the X-ray, you will have a possibility, because of the biplanar acquisition, AP and lateral, of doing stereoradiography and to be able to see if the implants are moving relative to each other, which would imply some failure of the fusion. But it's still something which is a very work in progress. When you combine everything, you can have some very interesting things. This patient was born with macular bright at birth. It was an antenatal diagnosis. People were thinking that she had a skeletal dysplasia. So it's a neonatal macular bright syndrome. She was followed for a significant amount of time before deciding to do anything. When they decided to do something at 3 years of age, it could only be a growth-friendly device. And she had a CT as part of the workup, and the CT was also used to assess in the 3-year-old non-compliant children the volume of the lungs. And it's something which is significantly important to monitor. So when she's 3 years of age, yes, she still has scoliosis, but everything has grown. Yes, the implants are there, and you can see that the lungs have developed and are within normal limit in terms of volumes. And this is probably an important point to go for surgery and to monitor, because these patients are too young to have any respiratory function test. So, ancient disease, new beginning, we have seen that we have moved from the conventional X-ray to still a conventional X-ray, but with a significant dose reduction. A conventional X-ray which provides some 3D capacity for a less important irradiation burden. And in terms of treatment, we have moved from adolescent idiopathic scoliosis to devices which can be used at the end of the growth and which are less invasive than the paraspinal rods. And when we have early onset scoliosis, there is a possibility of directed growth which provide correction of the deformity, growth of the spine, and growth of the lungs. Okay, thank you.